Meena?
Yes.
Yeah, thank you. I'd like to thank organizers for giving me this opportunity and holding this. I must congratulate them on holding this virtual meet in these times rather successfully. The topic for me to discuss is targets of hypertension in acute and chronic settings. And it cannot be overemphasized why we need to treat hypertension. It could really lead to all of these systemic complications, and many of the time the first presentation may be a complication because we know hypertension is a silent disease, and unless we actively seek to diagnose that, we may not diagnose it. But coming to the topic of the day, uh, 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 it's clearly known from both epidemiological studies, as we see here, and clinical trials, that blood pressure works as a continuum. It's not that the 140/90 is where you have benefit, where you have complications, and above and below which you don't have any. So as we can see here, the mortality from stroke and ischemic heart disease increases or doubles for every 20 by 10 millimeters of mercury. Similarly, the heart failure, aortic aneurysm risks are reduced by 50% if you have blood pressure which is 20 systolic or 10 diastolic BP lower than uh, uh, another person. So these complications work as a continuum. And even the benefits from the trials, again, those trials, of course, are usually targeted to sub targets, but many of them don't reach them, but still the benefits occur. So what I'm trying to say is the benefits of therapy are again continuous, as you can see here. For every 10 millimeters of mercury, systolic blood pressure reduction, and 5 millimeters diastolic blood pressure, we reduce the risk of coronary heart disease by 20%. We reduce the risk of stroke by 35%, of heart failure 40%, and mortality by 13%. So by reducing this level, we can prevent, by treating just about 40 people and reducing blood pressure systolic by 10 or diastolic by 5, we could prevent one event of CHD, stroke, or heart failure. So even these small reductions can give you a lot of benefits, is what is important. And as you can see, again, there are several such analyses, but I've taken this one from Law, published in BMJ, a very famous study of meta-analysis of 147 reduction trials, which again really shows no cutoffs, and the benefit is continuous. And the more you lower the blood pressure, the more benefit you get, and the benefits extend up to 120 millimeters of mercury. So then why do we need targets? Do we really need targets? So generally, while we should not obsess about targets, and we know the benefits are continuous from the data which I showed you, it is important that as physicians, we are trained towards a goal-oriented management, and that's why targets help. Of course, lowering BP beyond a certain level may not be beneficial or may lead to harm, or what is popularly known as the J curve. And thirdly, you need to find that sweet spot where you maximize the benefits of therapy and minimize the adverse events. And that's where the targets are set. So right from the beginning, when we had these guidelines, and if the most famous one obviously being JNC, and you look from JNC 1 to JNC 8, gradually there are always some targets. Initially, JNC 1 and 2 only had diastolic targets, and then of course we realized systolic is as important or more important, and you had systolic targets right there. And these targets have progressively come down because you have had better drugs to treat, and you've realized treating to lower levels give you more and more benefit. And until mostly it was 140/90 after JNC 5, but as we all know, in the last couple of years, this has plummeted further. And if we see CCAHA gives a target of 130/80 now, while ESC, as we'll see in subsequent slides, is more nuanced and talks about different targets for different individuals. So how are these targets being set? So these are based on several, again, such studies are available. This is a network meta-analysis which has compared reduction of blood pressure to different targets. For example, if you see here we are comparing of different targets with 120, 124. These are different targets with 130, 134. And you can clearly see that the benefits are more and more when you compare higher blood pressure, and the benefits kind of dwindle and become less as you compare, for example, 120 to 124 versus 125, 129, or 120, 124 versus 130, 134. So obviously, the benefits come down. So there is what we call popularly as law of diminishing returns. So you get far more benefits when you lower to 130, 140, but there is some incremental benefit smaller as you reach targets of 120, targets closer to 120. And as you can see here, so based on this, the recent guidelines have set these targets. We popularly think that AHA is 180, 130, 80, but it has to be, we need to read between the lines. And if you clearly see, it says that it's class 2B, except for the high risk cases and cases complicated by comorbidity, which are actually the minority. Most of the patients will be low risk, low cardiovascular risk. Hypertensive will be low CV risk patients. And if your CV risk is less than 10%, then 130, 80 is a class 2B. Otherwise, I would support being more close to 140, 90 in patients who have lower CV risk. ESC is a more nuanced guidelines, and it says that your first objective should be reaching the target of 140, 90, and we know loads and loads of hypertensives do not even reach those targets. And if you reach 140, 90, then you may consider lowering further, but no lower than 120. 120. So that it is for the first time sets a lower target also. So this is across this different groups. So clearly in the ESC guideline, it says that if you have CKD, you do not go below 130. And it also says in those above 65, again, sets targets of 130 to 139 and not less than 130, as it is for other groups like diabetes, patients with CAD, with stroke, TIA, where you could, if tolerated, go further down, but not less than 120. So that's how the guidelines are. But as we progress further, and I've just picked up two interesting studies where they've pooled data from a lot of trials, including the SPRINT, and they've looked at finding the sweet spot, and it could be very different for different individuals. So probably in the future, blood pressure management will be what it is like what is like lipid management right now, and where we know it's high intensity, medium intensity, low intensity targeting. So similarly, depending on your risk, and you could put this in a calculator and then see your risk and then determine your targets. Probably this is how the future of blood pressure targets are going to be. However, having said that, we need to be humble. And even this city of Delhi, when we surveyed in the population, we realized that just about 1/3 of the population is aware of the hypertension. 1/3 of them get a therapy, and hardly 10 to 20% of people are under control. So while we keep talking about these things in these such meetings, on the ground, our management of hypertension, unfortunately, is abysmal and leads to the cardiovascular risks that we are seeing all over as cardiologists. Coming to the second part of the talk, which is the targets in acute settings, the data here is relatively limited, and therefore the guidelines are actually far more sacrosanct as compared to the chronic guidelines. So it's very important when you see somebody with a very high blood pressure, very importantly, you need to distinguish whether it's a hypertensive emergency versus hypertensive urgency. An emergency are those where you have target organ damage, which is new or which could be progressive or worsening target organ damage. There, you need to be more aggressive. But if these are not there, most of the time it is called hypertensive urgency, and most of the time it is because of the fact that you would not have missed your therapy. So there you just need to start oral therapy. Don't be too aggressive with, we know what the side effects of subcutaneous depin has been. So don't be too aggressive. For hypertensive emergency, yes, we need to admit in CCU, and especially cases like if you have aortic dissection or if you have pheochromocytoma crisis, you need to aggressively lower systolic blood pressure to less than 140 millimeters, and in dissection to less than 120, and always use a beta blocker. For other cases of hypertensive emergency, we generally are less aggressive, and we reduce it by 25% in the first hour, then to 160, 110 in the 2 to 6 hours, and then subsequently in the 24 to 48 hours, reach our goals of 140, 90. So this slide just highlights how we differentiate different hypertensive events and try to lower the blood pressure, as I mentioned in the previous slide. I would just like to highlight cerebrovascular disease, which is a little different. And here you do not need to be aggressive in blood pressure lowering. So if you have somebody with intracerebral hemorrhage and very high blood pressure, intensive blood pressure lowering is indicated only if the BP is more than 120 millimeters of mercury. And otherwise, do not reduce the BP immediately, especially if it is less than 180. So in these situations, there have been multiple trials, the Interact 1 and 2, the Attach 2, and the practices are a little different between cardiologists and neurologists, but the guideline clearly says do not do intensive blood pressure lowering if the systolic blood pressure is less than 220 millimeters of mercury. For ischemic stroke, it's a little different. So especially if you want to thrombolize, then you lower the blood pressure if it is more than 180, 110, and try to keep it less than 180 by 105. Well, if you don't want to thrombolize, then we have to be more gentle in reducing the blood pressure, and blood pressure reduction in the first 24 to 48 hours is recommended only if the blood pressure of the individual with acute ischemic stroke is more than 220, 120.
We'll have to wind up, Doctor.
Yeah, that's my last slide. So the take-home message is that benefits of blood pressure lowering is continuous and is not binary. And absolute risk reduction of BP lowering is higher in high severe risk individuals. In high severe risk individuals, the benefit of BP lowering seems to extend till 120/80, but the quantum of benefit is less once we reach 135 or 130. And as said in the ESC guidelines, our first target should be 140/90 and then 130/80 in high-risk individuals only who tolerate these levels. And in acute settings, we need to be dependent on the underlying condition. So in conclusion, I would say we need to implement what we taught. Clearly, that's not very well seen in the reflection, not well reflected in the population in terms of hypertension control. Thank you.
Thank you, Dr. Ambuj. I think it was wonderful presentation on the targets, which are very different between acute and chronic settings, and very clearly said that the targets have been following constantly over the last so many decades, and possibly the J curve is still to be better defined. As you rightly said, less than 120 is possibly if the person can tolerate it better, but 130 and to 140 also, less than 140 is decent enough, because there is no major amount of benefit which you get in the chronic heart failure hypertension setting. In acute settings, there are still a lot of questions to be answered. I think as time goes by, we'll have redefined better outcomes. But as a general population principles, in acute setting, you can drop down the pressures faster as compared to in a chronic setting where we have to go a little slow. Dissection is an extreme emergency where you have to bring down the pressures immediately, as low as possible, less than probably 120, and CVAs and cerebral hemorrhages possibly go slow. So I think message is loud and clear. Thank you for your presentation, and we'll move on. Thank you.